He's here. He just joined.
Oh, okay. So, doctor, hello, doctor. Hello, Dr. Simon.
Miska, kindly give him a few minutes to settle in.
Oh, okay. So, since we have no volunteers for this week, who would like to share something with us as we wait for Dr. Ajin? Anybody home?
Hey, this is Emmanuel.
Okay.
Yes, so I would like to share something about the lungs. Yeah, the lungs. So I recently I was admitted for severe crisis, and later on I was told I had athleticis, that is like fluids and stuff in my lung, and like almost lung collapse, pneumonia, and I was on oxygen at the hospital, and also was using this spirometer, that is to blow air into my lungs and out. But after discharge, it's not been easy coping like I used to do. If I walk a few minutes, like a few seconds, I'm so tired, and like I have to just open my mouth and start taking in air. And it's not everywhere that you can take, you can just breathe like that. And mostly I find myself at places where I cannot do that. And because of the mask, I don't know what the mask is also, how the mask is also contributing to the breathing of people like us with sickle cell. But the mask has been so like a big thing and kind of traumatizing for so many people, whereas they said it does not prevent you from breathing. Personally, I believe it's just something out. It's kind of different if you don't have the mask on, and when you have the mask on. And some of us who have been working throughout this pandemic in this mask, and now even double masking and face shielding, it's kind of weird. And yeah, the lungs are so important to every human being, and like taking air into your lungs for your body to function very well. So if you are not able to breathe very well, as I'm not able to breathe very well now, even as I'm talking, I'm kind of tired. It's kind of frustrating, and I don't know if it's the same for people without sickle cell or people with that condition. But as for my personal story about the lung, as I recently experienced, that is what I'm going through. So that's my experience with the lung. Thank you.
Okay, thank you very much. So we appreciate you. It's my guess by now, the second one settled for us. Hello, Dr. Simon. Dr. Simon Ajin, yeah.
Yeah, hello.
Please, can you hear us?
Yes, I can hear you.
Yeah, okay. Oh, okay. Please kindly introduce yourself to us.
All right. Thank you, Priska. Yeah, my name is Dr. Simon Ejin, a medical officer at the Ghana Institute of Clinical Genetics. We basically deal with people with sickle cell disease day in and day out.
Okay. So you can please continue with your presentation. Thank you very much.
All right, thank you. Please, I've been at Priska, I'm coming. Priska, can you go ahead? Give me some few minutes. I'm having some technical issue. I'll be with you in a minute. Hello, Priska. Hello, Priska.
Simon.
Yeah, Priska, give me a minute. I'm trying to open my file up. Okay.
Okay, sure. Okay, so while we wait for Dr. Simon, does anyone else have anything else to share about sickle cell disease and the heart and lungs? Has anyone experienced any medical issues related to their heart and the lungs due to sickle cell?
Hello, can you guys hear me?
Yes. Welcome.
Yes, hi. Thank you. This is Dr. Asari. And I don't have sickle cell, but I know I think it was Emmanuel who commented earlier about his situation. I actually, unfortunately, I suffer from allergies. And most people think, oh, allergies is nothing. But I have severe reaction to trees and grass and animals and everything. And so in the spring, where I am here, when all of the trees go into blossom, I actually start having allergic reactions so badly that when I walk just walk a little bit, I actually was finding myself, I couldn't breathe. And it felt like I couldn't get the air in my lungs. And I actually had to go to the urgent care center last year, or I think last year, the year before. I've had to go a few times, and they've had to give me humidified oxygen, nebulizer, and medication. And it is horrible because your whole body is tired, you're completely stressed, you can't get the air in, you have headaches, and it can be really scary. And although I don't have sickle cell, I never realized, even as a physician, I never realized how badly allergies could affect you, to the point where I'm sitting in the urgent care center. The doctor's like, your lungs are tight. They hear wheezing. There's basically no air entering the bottom half of my lungs. And so they had to open me up. I was in treatment for like a few hours. I think when Emmanuel was asking about other people, whether it's just sickle cell, the lungs can be affected by so many different conditions like allergies or like asthma, even if you don't have sickle cell, and you can actually end up with a very similar picture. So I just wanted to share that story.
Hello.
No, I wasn't able to hear your story.
Hi, Dr.
Hello.
Asari. I heard part of
Hello.
it, but like the line went off.
Yeah, I wasn't hearing anything.
Oh, I'm sorry. I don't know where the last thing you guys heard, but I was just saying that I don't have sickle cell, but I have allergies. And I ended up, because of my allergies, there was histamine released and everything in my lungs. And so my lungs started closing up. The alveoli, which are the lung sacs that the air comes into, they were closing up. So I was having a difficult time breathing. And a lot of people don't think of allergies as a possible life-threatening situation, but I realized what was happening with me, and I actually had to go to the urgent care center to get oxygen and medication. And it was really bad because I couldn't breathe and I was having problems. Like I couldn't really focus. I couldn't concentrate. So to Emmanuel's point, I just wanted to say that even if you don't have sickle cell, you can have lung conditions or an acute situation that happens that can present very similarly to someone perhaps who does also have sickle cell. So conditions can affect the lungs and they present in very similar ways. And then we too also have to get nebulizer and oxygen and albuterol and all of that to open up our lungs so that the air can fully come in. I hope you guys were able to hear that.
Yes, doctor. Thank you very much, Dr. Asari. Lots of technical issues today, but we will get through this. So Dr. Simon Agin, please, if you are ready, you can take us away.
Hello, everyone. Good evening once again.
Good evening, sir.
Yes, so Dr. Simon Agin, like I said earlier on, I'll take everyone through a quick discussion on the sickle cell and the heart and the lungs. I'm sure everyone know, definitely know what the heart is and the lungs too are. We all have one heart and we have two lungs, the left and the right lungs. And basically they function in a way that enables us to be able to get enough oxygen delivered to various tissues in the body. And so if the heart and the lungs are not really functioning well, definitely we won't be able to function as humans again. I'll begin by giving an outline of my discussion, which I'll have a brief background to what we discuss, two clinical scenarios. We'll have something on the lung manifestations, which has to do with those with sickle cell disease, and the effect on the heart, which I mean the same for those having sickle cell disease. And I'll have a quick summary and my references. So on the right, you can see a picture of one of my colleagues, Sylvester, wearing one of the sickle cell phenotypes, which is AA. I mean, AA and the other lady having SS. So it's quite important that we all get to know our genotype or our phenotype so that we can be able to address all the medical issues that comes with having either an abnormal genotype or having the normal genotype. So like we know, sickle cell disease is basically you having an abnormal red blood cell. I mean, there are a lot of mutations or changes that will happen at the molecular level and even at, that I'm not going to discuss that today, but definitely at the end of the day, you realize that those having sickle cell disease will manifest, or you might see their red cells to be a bit different from the normal rounded shaped red cells that we see. On the right, you see one that is shaped like a sickle, and the other one on the left, which is shaped round, and that is the normal one. The one on the right is the abnormal red cells that we know. That denotes those having sickle cell disease. Please, are we all following?
Yes, doctor, we are with you.
Yes, please.
So, sorry. Sorry. So, like I said, sickle cell disease is an inherited disorder of red blood cells. So definitely before one will manifest or have the sickle cell disorder, either your father or your mother should have one abnormal red cell so that you can acquire two abnormal, these genotypes or these genes from your mom or your dad. So once you acquire these abnormal genes from your mom and your dad, you inherit what we call a sickle cell disease, in that the person has two abnormal genotypes, in that there are a lot of changes, like I said, where valine will replace glutamic acid on the sixth amino acid which are more of a technicalities that has to do with you acquiring the sickle cell abnormality. The others we know are the hemoglobin SC, others are hemoglobin S beta thalassemia, either the O or the plus. Okay. So the two quick clinical scenarios that I had, it has to do with a patient that reported just this Thursday, which is the A, and the one that the patient came to the hospital on the Friday, just this past Friday. The first one actually asked me that, doc, I sincerely don't know what is happening to me. My breath is not enough for me these days. I told my mom and she thought I was exaggerating. It is not getting better either. It predates COVID and I'm not coughing or experiencing any chest pain, but I just can't get enough air into my lungs. And she doesn't really know what is happening to her. This is one of our patients that reported on Thursday. The other one reported on Friday that she has a 2-week history of palpitations. I mean, I think she has reported to some private hospitals around and nobody seems to know what is happening to her. They all say that her blood pressure too is fine, but she's been asked to do some investigations and was prescribed some blood pressure medicine at one facility to control the symptoms. She's asking whether the symptom that she's having is normal or is not normal for a sickle cell patient. Okay, so basically this is what we are going to discuss through, the time that we have now. So if you look at the pathophysiology of how people even get this clinical manifestation or get this clinical condition, like we know, the sickle hemoglobin or the sickle-shaped red cells, the hemoglobin within these cells, whenever they are deoxygenated, they are able to polymerize into an elongated rope-like fibers. This makes this red cell not able to change the shape and able to distort its normal rounded shape that we see. And it accounts for most of the vaso-occlusive crisis that we see. Like we say, patient has a crisis because the deoxygenated red cells are not flowing like they are supposed to flow anymore. And we see that as part of the manifestations that sickle cell patients will day in and day out come to the hospital with. And like we know, either they come with crisis or they will come to the hospital hemolyzing. So you will realize that either their eyes become quite yellow or their urine quite become dark. And sometimes they can come with abdominal pain, either the liver or the kidney, the spleen is enlarged. And most of the time, whenever they come, we always have to see that the form of crisis they are having has resolved before discharge from the hospital. And it's quite an emergency. So nobody comes to the hospital either in the form of having a vaso-occlusive crisis or with hemolysis will be treated lightly. So with the clinical manifestations, like I said, the hemoglobin polymerization accounts for majority of the things that we see in sickle cell patients. But we also know that there are other changes that happen to the red cells that also affects either development of a vaso-occlusive crisis or hemolysis. And it has to do with sometimes how the cells adhere to the vascular endothelium and also the membrane structure and the function of the cell, and also the cell volume control. Okay. We've been seeing quite a number of cases at the facility. I mean, I'm talking about a sickle cell unit, where either they will come in the form of either in an acute state or with a chronic, either a cardiac or pulmonary condition. And that is what accounts for majority of the morbidity and mortality we see in people having sickle cell disorder. So this is the normal structure of the airways from the nostril all the way to the lungs. Realize that from the top, you realize that there's really nothing that's supposed to obstruct an airway unless there's either a foreign substance or the person has enlarged adenoids or something. Other than that, we realize that people with sickle cell, they also have this same structure like any other person, but they will develop complications that will either manifest in the form of not being able to breathe well or their lungs actually getting infected. And in that case, they need urgent care. So I'll quickly move to sickle cell and the lungs. So the acute manifestations or the things that patients will manifest in the facility or they will visit the hospital with are mostly either an acute chest syndrome, which is one of the major causes of mortality and morbidity in sickle cell patients, or either they will come with pulmonary thromboembolism, in that a clot or either fat will move from either their bone marrow or any part of the body and gets lodged into their lungs. Or sometimes they will come with episodic respiratory symptoms, either in the form of asthma. So somebody will actually manifest or probably come to the hospital that they can't breathe, they might be wheezing, they may be struggling to get air down and all that. And doctors might even diagnose them of having asthma. It could just be an acute manifestation of one of the complications of sickle cell that has to do with the lungs. The chronic manifestations we tend to see are that people will either come with abnormal pulmonary function. So one of the things that we do at the clinic is that we occasionally ask them to go and do spirometry. So within a year or probably after 2 years, we will ask you to go and do spirometry just to see how your lung is functioning. And a lot of time they will either come in the form of air restrictive disorder that has to do with their airway. So they are not able to really get enough air in and out of their lungs. So the lungs in a way become restricted in its function. And sometimes they will either come with very low oxygen saturation. So sometimes the patient came that, why is it that her SpO2 is always down? So whenever she checks her SpO2, it's around 90, sometimes 88, sometimes 89, 90. It never goes beyond 96 or 94, and can compare that to other relatives who are having either 99 saturation and all that. And it's one of the chronic manifestations of sickle cell disease. Occasionally, we also see people coming with pulmonary hypertension. So in that the pressure within the pulmonary vessels are really high. And in that when they come like that, it's quite an emergency and doctors need to attend and do all the necessary investigations and be able to manage them. Like one of the brothers said, exercise intolerance is one of the things that you might see most of the time. They can't really do much. They do little, then they are very tired. They work for a while, they can't really be able to cope with. And it's one of the chronic manifestations that we tend to see with sickle cell patients. Like I said, the chronic lung disease that has to do with sickle cell disease encompasses all this. Either they struggle to get air down their airway, they have exercise intolerance, they have chest pain that whenever they breathe in and out, they're able to, it either worsens or it gets worse with time. They also have progressive deterioration of their pulmonary function. So you tend to do spirometry from time to time, realize that the function keeps on dropping from time to time. And it's quite one of the things that you tend to see in people having chronic lung disease in sickle cell anemia patients. So it's very important that we do cardiopulmonary assessments in both the acute and the chronic states to know what effective measures, and if they need be, we tend to also do work together with the respiratory physicians so that they can be able to address their airway problems. Basically, these are the things that we tend to see with sickle cell patients. That has to do with the acute manifestations and even the chronic forms of disorders that they get with their lungs. There has been a lot of, let me say, projects that has been carried out that has to do with the chronic manifestations that we see with sickle cell disorder that has to do with the airway. There has been a lot of ideas that came up that it's likely due to the chronic ischemic episodes that they get that might have manifested like that, or either it has to do with the perfusion disorder, in that occasionally blood doesn't flow to part of the lungs, and all of a sudden you get blood flowing to those areas, and you get a lot of reactants, which either causes some lung injury to that particular area of the lung that were deprived of blood. We also get a lot of changes that happen to their blood vessels. So we get pulmonary vasculopathies. So they develop pulmonary hypertension. Either it gets resolved or it doesn't get resolved. Then later on, they get this complication that has to do with their airway. There are also changes that happen to nitric oxide metabolism. Nitric oxide basically helps in either vasodilation or vasoconstriction of the blood vessels within the pulmonary system. We know that getting to understand this concept will really help us to develop better strategies and better methods in addressing all the lung manifestations of sickle cell disease. I'll pick one of the acute manifestations, which has to do with the acute chest syndrome. Acute chest syndrome is one of the things that we fear most. And most of the time, any patient that even come with vaso-occlusive crisis is being addressed in that direction, because we know that if we're not able to address this acute vaso-occlusive crisis they are having, it might definitely lead to an acute chest syndrome. There has been a lot of changes to the definition, but it has to do with anything that has to do with the airway. So now any infection that has to do with the lungs can be classified as an acute chest syndrome. But previously, we know that if a patient gets a new infarct that has associated respiratory symptoms like I can't breathe well, I'm spiking temperature, I'm coughing, and all that, we classify all those individuals as having acute chest syndrome. There are a lot of risk factors that put people at risk, or there are a lot of factors that put people at risk of developing this emergency or acute lung problem. So like I said, patients admitted are always seen as a prodrome to developing an acute chest syndrome. So acute chest syndrome, appearance of a new pulmonary infiltrate on a chest X-ray associated with fever, respiratory symptoms such as fast breathing, wheezing, coughing, and having a chest pain. So the factors that usually leads to people developing acute chest syndrome include them getting infections. If you have embolic phenomenon, either from the bone marrow infarction or fat embolism, sometimes you can actually get pulmonary infarction from this, from the patient developing thrombosis in the pulmonary vessels. When the patient is not able to breathe very well and splints a part of the lung or the ribs, that it will not be able to breathe in and out well. It also leads to the patient developing atelectasis. And with them, they will not be able to supply enough lungs or enough oxygen to the red blood cells for them to supply to the extremities or the tissues in the body. And such episode can also lead to developing acute chest syndrome. And so we always emphasize on the fact that whenever a patient is in pain, if you have a spirometer around you, you need to use the spirometer from time to time. And so not that it won't lead to you developing a lung collapse, and that if you have a lung collapse, you'll definitely not be able to get enough oxygen to your red cells for them to deliver to the tissues of the body. Occasionally, like how the peripheries, how they treat patients most of the time, that they hydrate a lot of them with a lot of fluids. Sometimes when blood transfusion is not really needed, some will give massive transfusion, like giving more than 3 liters in 24 hours. Sometimes people overuse opioids like morphine, pethidine, tramadol, and all that. Patients will actually request for these pain medications, and all these medications can actually lead to you developing acute chest syndrome. Like I said, if you overhydrate such patients, they will develop pulmonary edema. And when pulmonary edema sets in, it will affect the pulmonary vascular permeability, and it will be able to lead to developing acute chest syndrome. I won't bore you guys with the clinical things that we usually look at. What I would say is that most of the time, when patients come in an acute state and we do an X-ray, it's usually 1/3 of them that will have, 1/3 will usually have normal X-rays. So you may not be able to see an acute pulmonary infiltrate, like the person has done an X-ray before. You won't be able to see another X-ray showing you a classic symptoms or classic lung infiltrate for you to diagnose acute chest syndrome. So we usually base our diagnosis on the clinical findings and what the laboratory will support by the leukocytosis and things like that. We will combine the two, and based on your SpO2, we will be able to decide whether the patient is having an acute chest syndrome or not. So like I said, you can come with acute pain, like a sudden onset of pain, either on the left or the right side of your chest. A doctor will definitely investigate and examine you well to decide whether you have developed an acute chest syndrome. On the right, you could actually see part of the right lung, the lower zone. You can see an area of, let me say, whitening, like you all see, that particular part of the lung has been affected, and it's likely the person has developed. It could be an old one, but it's likely a new infiltrate that is being shown on the picture here. So with the management, like we do, oxygen is very important. So we tend to supplement them with a lot of, with oxygen, especially if you know your SpO2 is dropping a bit faster. And even if SpO2 is fine, we tend to give you oxygen so that it can help with recovery. Antibiotics are always needed. So we tend to give you broad spectrum antibiotics. We give you enough pain medications to help. Transfusions are not always needed. But sometimes, if the need be, we have to also talk to the hematologist to decide whether exchange transfusion will be quite important for you, or we should do just a normal, simple blood transfusion. The use of bronchodilators will be useful for people with a history of asthma and hyperactive airways. We also need to support them by monitoring them, letting them do the incentive spirometry, making sure that if they can drink, it's better rather than giving a lot of IV fluids. It is very important that people that come with acute chest syndrome or they develop sickle cell chronic lung disease will have to be monitored on the long-term basis. It's quite important that the hematologist is involved, the respiratory physicians are involved, so as to help these people recover from the acute episode that they had. Like our brother said, you could have the acute episode, you think that probably all things will resolve in a minute or within a month, but it could persist and lead to a chronic form of manifestations of such disorder. So hello, can you hear me?
Yes, sir, we can hear you.
Okay. So normally someone will ask, why do sickle cell patients develop pneumonia like that? Or why do they get infections a lot? And these are things that we keep on saying day in and day out for people to understand that it is not something that every sickle cell patient is supposed to get infections or develop pneumonia, but there's an issue that has to do with your host defense. So your immune system is not able to fight some form of infection, like we always say. So there are some infections that will get introduced into your system, or you probably get you acquire, and these infections will be able to affect you so badly to the extent of you even developing acute chest syndrome. You also lose the ability of producing or protecting yourself with antibodies, because your spleen may be gone by the time you realize. I mean, they get autosplenectomy a lot. Sometimes so they are macrophages, or these organisms that are organisms that fight infections and all that will not be able to function the way they are supposed, or their white cells, they are supposed to function in a particular manner. They will not be able to function that particular way for you. So you have issues with dealing with some form of infections, okay? So we mentioned some few infections like streptococcus pneumonia, H. influenzae, mycoplasma pneumonia, chlamydia pneumonia, and all that. These are Neisseria. They are all part of encapsulated organisms that can really affect sickle cell patients a lot. We always want the hematologist to come in, especially when people develop acute chest syndrome, so that they'll be able to monitor them very well and be able to address their issues as and when they come in. With the chronic management, it's always aimed at preventing recurrent episodes of such acute chest syndrome and even other manifestations like chest pain. I mean, people are constantly coming with chest pain, and sometimes you barely can help them. You give them pain medications today, they will go and come back again that the chest pain is still persistent. Sometimes it could be a background pain for them, but that background pain is so intense that they are not able to really deal with it well. Hello? Hello, Priscilla,
Hello.
can you hear me? Yes.
Yes, please, we are here.
My line can break. Okay. So I'll quickly summarize whatever I said on the respiratory system. Sickle cell patients are likely to come with acute manifestations and also occasionally with the chronic forms of disorders or primary forms of manifestations, like we know. So the acute forms that we are usually scared about has to do with the acute chest syndrome. And as I said, it's a new pulmonary infiltrate. That is, you have developed a problem with part of the lungs. And this particular problem that you have developed will either let you come with chest pain, or you may be breathing faster, or you may be struggling to get air down your airway. And sometimes too, it gets to the extent that you feel your airway it's really crashing, like your chest is crashing in. You can't breathe out like you want to. And this is one of the things that cause a lot of mortality or a lot of death in sickle cell patients. And so whenever you go in an acute form of, with acute form of pain, you are likely to be treated like somebody who has acute chest syndrome. And so if you go and doctors are addressing you in that manner, I don't think it should really be something new for you, because we are afraid that you may develop acute chest syndrome. So I'll quickly move to the cardiovascular system, or the heart. The heart is basically like the engine of the body. So the heart is supposed to pump blood, which contains your red cells. And the red cells are supposed to be normal. But in sickle cell disease people, they have abnormal shaped red cells. And as I said, if the red cells are deoxygenated, it changes the shape and it affects its flow and back to the heart, for the heart to get oxygenated again, for it to pump it back into the tissues all over again. And so we also get recurrent episodes of them not getting enough oxygen to the peripheries or the vital organs of the body. And it's likely that when you don't get enough oxygen to parts of the body like the bones or the muscles, you will definitely come with pain, because there will be buildup of waste in this particular part of the body. And that is what we usually tend to see with people coming in an acute state. With the chronic forms of hemolytic anemias, like we say, either people are constantly getting their eyes either being yellow, or they are passing dark urine most of the time. And so it could be one of the manifestations that we see that has to do with the heart and the blood vessels. Yeah. So commonly, one of the things that we see is that people develop proliferative systemic vasculopathies. Like I said, you getting pulmonary hypertension, okay, or getting your ventricles not being able to function the way they are supposed to function. And as I said, a lot of times you hear doctors say that you have sickle cell cardiomyopathy or sickle cell cardiomyopathy, in that you have a problem with either with the diastolic function of the ventricles or with the systolic function of the ventricles. And we always want to identify these people early enough, do all the necessary cardiac investigations that we have to do, and be able to treat them as high-risk patients, even among the other sickle cell patients. With people developing pulmonary hypertension, we realize that it's not just with pulmonary hypertension that they tend to get intravascular hemolysis. They also develop leg ulcers and renal issues. They get iron overload and liver dysfunction. And so people with chronic anemia in sickle cell disease, if you have sickle cell disease and your HB could be normal, could be around 10, 11, 12. But others who come with blood levels of around 6, 7, and sometimes up to the extent of 3 and 4. Such people will definitely have issues to do with the heart chambers. So the heart will give up, because the heart will also need oxygen or need blood to be able to function very effectively. So if they are not getting enough blood or oxygen to be able to do that, they will definitely go into some form of failure. So we tend to see them having dilated cardiac chambers, or otherwise sometimes the ventricular wall becomes so huge in that the heart is overworking to be able to pace or to be able to keep up with the pace that the blood is really dropping. Because if you have very low HB, it means that your heart has to now overwork either 2 times of how it used to previously function. And so it's one of the factors that tends to affect sickle cell heart, because the heart walls will either become so thick or the chambers will become dilated with time. And this is one of the factors that tends to affect people that cannot really be able to exercise very well. And when it comes to sickle cell cardiomyopathy, it's one of the causes of sudden death. The person could be there or have developed cardiomyopathy, and all of a sudden arrhythmias and things will set in, and the person could just pass on or probably die. Okay. So we spoke about the ventricular function. The diastolic and the systolic functions could all fail you, and the person will not be able to increase their cardiac output to meet up with the reduced oxygen that is flowing in the blood vessels. And this is one of the things that we tend to see in people developing, people who are having low blood level and they are not able to function very well. So I think it's a repetition. When you do chest X-rays, you may see their heart very huge. Okay, sometimes you could actually see their chest wall moving in and out like that. It's very hyperactive. Sometimes you could hear hemic murmurs or some murmurs on their heart, or like the heart may be having extra sounds. Okay, and all this has to do with the state of their blood level. It has to do with the pulmonary hypertension they are developing, and also the thromboembolic phenomenon they will be developing in their blood vessels. That has to do with their with the sickle cell disorder. And like I said, heart failure is not common. We don't see heart failures a lot, but usually when we see people developing heart failure in sickle cell, then either they are very old or they have other medical conditions like hypertension and kidney failures. I won't go through all this. Like I said, we do a lot of series of tests for them to check their cardiac output and whether even if they develop cardiomegaly as one of the manifestations of the heart. So if the heart becomes too big, definitely once we do our chest X-rays, we're able to identify that, okay, then after that, we definitely have to do an ECG and follow up with an echo. And basically when we are addressing people with this cardiac output defect, and also with cardiomegaly, we tend to work hand in hand with the cardiologist, sorry. So I said earlier on, they tend to have left ventricular dysfunction, either with the diastolic or with the systolic function. So they will not be able to pump enough blood out, and the heart walls may be so enlarged, or the ventricles will be enlarged to an extent that it won't be able to work effectively. It has been shown that people with diastolic dysfunction and pulmonary hypertension tends to have poor prognosis, especially if a sickle cell patient develops pulmonary hypertension and have diastolic dysfunction. It tends to be one of the poor prognosis that usually the cardiologists tend to struggle to even address their issues for them. A follow-up with echoes and ECGs, like I said earlier on, tends to help. And usually we do that at an early age. And there are a lot of things that have been said that people even develop both the systolic and diastolic function at an early age, like even within children and adolescents. That's why it's very important that doctors have to constantly do ECGs and echoes for such patients. With the issues of developing iron overload, like we know, the cells hemolyze every 21 days averagely. And so when they hemolyze, the iron still stay in the system, in the body. And so if a sickle cell patient constantly either is being transfused or consuming iron supplement, it's likely that you will get iron overload. And this iron tends to deposit on almost all tissues, especially your heart. So once they deposit there, they will affect the function of the heart and it will not be able to work very effectively. And it's one of the things that tends to affect the heart muscles. And people who have this iron overload will also definitely be producing a lot of toxic reactants or reactive oxygen species. And this also tends to damage a lot of tissues in the body. So we won't advise any sickle cell patient to be consuming iron supplement, or even when they are being transfused constantly, doctors are monitoring their iron levels to know whether it's getting beyond the upper limit so that they can be able to address iron overload for them. With pulmonary hypertension as one of the commonest or one of the major complications that develop that has to do with the cardiovascular system, it tends to either manifest either that I can't breathe or I'm having chest pain, or when I do something small, I get tired. Sometimes they can either come with coughing, blood and all that. So pulmonary hypertension is one of the things that can also affect sickle cell patients, although it can also affect other people. It's one of the things that we see in sickle cell patients, and it plays a major role in mortality of a lot of sickle cell patients. And initially, like we thought that it was purely the vascular occlusion by these rigid blood cells. But we also realized that it also activates your coagulation cascade, and also your platelets get activated, and they also play a role in developing these vasculopathies. We'll bore you with all this. The management is almost the same, like all the doctors will do. They will follow up with your cardiac enzyme, your ECGs, your CTPAs. They will do proper hydration, your oxygenation. They will give you enough pain medication. As and when they need to transfuse you, they will do your exchange transfusion. So assessing the patient's function, assessing the cardiac function of every sickle cell patient is mandatory. So every doctor is supposed to check either once in a while to decide when to do ECGs for such patients. They can be doing every year for this patient, so that as and when the problem develops, it can be addressed immediately. I think basically this all has to do with the cardiac manifestations that we tend to see in sickle cell patients. And as I spoke earlier on, the pulmonary hypertension, the ventricular dysfunction, that has to do with either your heart will get dilated and will not be able to pump enough blood out, or the ventricle wall becomes so thick that it cannot be able to function very well. And as such, will lead to you developing cardiac arrhythmias. And once you develop a cardiac arrhythmia, you can die easily. I quote this, that out of 7 have emerged the strongest souls by Cahill. I never knew a lot about sickle cell disease. I was a medical officer. I came to the department, but what I have learned within this short period has taught me so much, that how I would have addressed somebody on the periphery, how to, probably attend to a patient with sickle cell disease, it's completely different now. And now I have more empathy for people with sickle cell, because I think what they go through is something that I cannot even bear. And they are one of the strongest people you either come in contact with. And I think a lot is quite important that we also get to know much about the disorder and be able to deal with it as and when. With the lung issues that you will get, and even with the cardiac issues that you could get from this disorder. I will end here, and I'll say that sickle cell is a journey I've never planned or asked for, but I choose to love life, hate the disease, and fight. I want everybody to have this at the back of their mind, that although these complications may come or may not even come, and even if they come, you should know that you'll be able to defeat the disease and be able to survive. I've seen people around 81, 90. I mean, the woman that I saw on Friday is 78 years, and she's very strong. She said the last time she had a crisis was about 10 years ago. She's never had crisis again. And I'm very happy for them. And I must say that these are things that we, the doctors, even managing them, are scared of, you developing a cardiac or a lung issue. But we know that once they come, there are doctors or there are physicians who will be able to address these medical issues for us. I will end here, and if you have any questions, you could ask afterwards. These are my references. Sorry.
Okay. Thank you very much, Doctor. Today, you've showed us too many technicalities, but we'll try and still and understand everything. So, okay. So, I think when you were doing your presentation, Dr. Asari wanted to add something to it. So, Dr. Asari, please, I'm giving you 2 minutes.
Oh, okay. Sure. I just wanted to add that when it comes to the chest pain that happens, a lot of times the first thing physicians or clinicians will look at is acute chest syndrome, because that is really a situation that can be life-threatening, right? Whenever we have a patient coming in, we like to look and assess the patient based upon what's the most critical thing that could possibly happening when we're trying to diagnose it. So a lot of times doctors will automatically go to acute chest syndrome because it can be so scary. However, I think a lot of physicians need to also pause and look at other things that are going on in the physiology of the human, meaning how the body is reacting and how the body is living. So actually, when they come in with pain, and a patient, somebody who has sickle cell may say, oh, I have chest pain. And what's happening is that there's pain in their ribs, right? And we know the ribs go around the body and they encase the lungs, almost like a shield. So what is actually happening is the inside the bones, the marrow, which is the area that makes red blood cells, is overproducing the red blood cells because the patient is having a crisis and their blood cells have sickled and changed shape and they're not getting enough oxygen. So the body realizes this and starts to push the bone marrow to make more red blood cells. And while it's pushing and pushing and pushing, that actual push causes a bone pain. So it's really important to understand that that bone pain isn't, that chest pain could actually be bone pain from the body trying to make more red blood cells. And that pain is being referred, or it feels like it's coming into the actual lungs. So it's really important that everybody remember that as well. That's just what I wanted to share.
Okay, thank you very much, Dr. Sari. So if you have a question and you want to ask, you can raise up your hand, or better still, send it to me and I'll read it for you. When you raise up your hand, I'll call you. Then you unmute your microphone and talk or ask your question. So, Doctor, are you there?
Yes, I'm here, Priska. I'm here.
Okay, so time for questions. Please, someone is asking that you mentioned the spirometer. So does it mean that every sickle cell patient has to get one at home and use, or?
Yes, thank you. It's quite important now that we try to purchase one. I know it's quite expensive. I think it's about 200 cedis or 220 cedis or so. But I think it's very important that we get a spirometer at home. Whenever we are in any form of crisis, as a form of chest physiotherapy, we could be using the spirometer from time to time so that we don't even develop the acute chest syndrome in the first place.
Oh, okay. Okay. And then Mudi, another budget. Okay.
Hi,
So,
Priska.
yes.
Yes, and in addition to the spirometer, there's I think a lower cost option at the physiotherapy unit in Kolebu. I think that one is less than 100 cedis, so you can check it out. But also for the people who have serious financial constraints, I know that on the wards, what they make them do is to blow balloons. So you keep blowing the balloons like to the maximum it can go, and then that forces you to expand your chest. So for those who have like serious financial constraints, you can also try that whilst you save up to get your spirometer. In addition to that, try and get a pulse oximeter, a thermometer, and other things, especially since we are in COVID times and we are limiting how much we go to the hospital. I have a question from Facebook. Can I ask it now?
Yes, please, you can.
Okay, so Mina is asking, I have a pain in the left arm. It runs from my shoulder through the chest down to my ribs. It's just the left part. And it started yesterday. She wants to know what she should do. So Dr. Simon, please, what should she do?
Yeah, hello. Yeah, can you hear me? Priska?
Yes.
Yes, please, we are here.
Yes. So I think if the pain just started yesterday, it would be important for her to really be able to address. It could be just a mild pain that she's experiencing, or it could even be moderate or very severe. And if it's very severe, she would definitely need to visit a hospital to be able to for them to be able to address that. And as I said, it has to do with the chest. So it's important the doctor listens to the chest and be able to know whether the air is really moving very well to all the lung zones and all that, and whether there's any even additional sounds which are coming into the chest that the doctor has to address. If the doctor thinks it's just crisis that she's having, which has to do with the left shoulder. I mean, I'm sure with pain medication and hydration, you'll be able to address. If the pain is not so severe and she's at home, she could start with any pain medication that she has around. And still, as I said, if you have a balloon at home, you could use. If you don't have a balloon at home, you could. If you have a spirometer too at home, you could use a spirometer and be able to drink a lot of fluids now. You need to hydrate very well. Okay, if after 24 hours you realize that the pain is still persistent, then you need to visit a hospital for them to look at that for you.
Okay, thank you very much, doctor. Okay, so someone is also asking, at what frequency should chest pain be a concern?
All right, so thank you. So right now we're advocating that within 24 hours, if your pain doesn't wear off, you need to visit a hospital, especially if it has to do with your chest.
Okay, doctor, I know whilst you were presenting, you explained this, but I still want to ask you, in a layman's language, how can we prevent lung conditions?
So commonly, you will be struggling to get air down your lungs. Let me say it that way. So you'll be gasping you'll be struggling to breathe, or either you'll be breathing too fast. So anybody at all standing by you or you yourself could realize that your breath or probably the rate at which you are breathing has increased, okay? And sometimes whilst you are breathing, you may be coughing, okay? You may be having some tightness. You know, sometimes some people feel there's some band around their chest, okay? So having all those symptoms, like the common three, like I said, will definitely be pointing that there's really something wrong with your chest or with your lungs, and you need to let the doctor assess and know what is happening there.
Okay. So another question, please, do people with sickle cell get the pneumonia vaccine, and how is it available in Ghana? I don't know if I got the name right.
Hello, Pesca, can you hear me? Can
yes,
you come again?
please.
Sorry, I didn't hear you.
Okay, somebody was asking, do people with sickle cell disease have to get the pneumonia vaccine, and how is it available? Is it pneumonia? Yeah. So, is there something like that?
No, we are not giving anything like that our unit now.
Oh, okay.
I think it's the pneumococcal vaccine you're asking about.
Pneumococcal. Oh, okay. Yeah, so yes, we give to some few isolated cases, but I think it's something that the children's unit has been doing a lot for us. So before they get transferred to our end, most of them have either received the vaccine or yes, in one way or the other. So the children unit tends to get vaccinated before, or they get them vaccinated before they transfer them to the adults. Yeah, I think.
Oh, okay, so I think we are done with our lungs question, and I want to ask, this one is for the heart. Does broken heart gives heart pain? Because I had this in our discussion.
Yeah, so I think that there's a disorder, like we said, the broken heart cardiomyopathy, or there's a name for it, I've forgotten, but there's something like that could really manifest like you having an acute chest syndrome. It still has to do with your heart. And as I said, if there's some history like that, you always need to tell the doctor about it. And I'm sure your doctor will be able to differentiate whether it's coming because of the broken heart that you had, or it's something quite serious that he needs to address.
Oh, okay. So it can really affect your health.
Yes. You had a broken heart?
No, please. It's not me. Okay, so please do. Does anyone? Please, if you have a question, you have to. Okay, it looks like nobody wants to ask any question again. Doctor, thank you very much for your time, for explaining things to us. I hope you've learned a lot.
Yes, I use a lot of technicalities, so I'm sorry. Next time, probably we'll come to your level. Okay.
Because I don't understand. I'm a business student. I don't understand anything. So next time, just come down to our level.
All right.
Okay, thank you very much. All the same.
Priska, we'll continue the conversation on the support group. So for anyone who had questions about what he said, you can just ask specific questions about anything you didn't understand so that we continue this conversation. Thank you very much, Dr. Simon.
Thank you, Nam.
Thank you, Doc. We've learned a lot. Thank you.
Thank you very much, Doctor.
Okay.
Thank you.
Okay. Thank you, everybody. Thank you for making it. Thank you for coming
sexy.
here. I really appreciate everybody.
Sexy. Thank you.
Okay.
Hey,
thank you. You're welcome. Okay, thank you very much, everybody. Have a good night. I love you guys. Bye-bye. God bless everybody.
Love you too. Bye. Bye.
Love you.
See you in 2 weeks. Bye.
It's okay. Bye-bye.
Bye.